بسم الله الرحمن الرحيم. أنا الدكتور أيمن Eldorf, Assistant Professor of Obstetric and Gynecology at Tanta University Hospital. Our lecture today is about urinary tract infection during pregnancy. At the start, you must know the definition of urinary tract, which is a bacterial inflammation in the urinary tract. You also must know that pregnant women are at increased risk of occurrence of urinary tract infection during pregnancy, and this usually starts from the 6th week of gestation up to the 24 weeks of gestation. Why urinary tract infection is common during pregnancy? This will be discussed in the next slides. At the start, you must know urinary tract infections are frequently seen or encountered during pregnancy, and also you must know that pyelonephritis is the most common serious medical complication seen during pregnancy. It's not the most serious medical condition, but it's the most common one. So we found many cases of pyelonephritis with pregnancy, which is a common complication or the common medical condition seen during pregnancy. For the good luck and fortunately, urinary tract infection is usually have a good treatment and excellent outcome, but in some cases it may become a serious complication with high maternal morbidity and mortality. Why this occur? Why urinary tract infection occur? At the start, you must know that the organisms that causes urinary tract infection in the pregnant woman are the same of uropathogens or the microorganism which causes urinary tract infection in the non-pregnant patient. And Escherichia coli is the most common organism isolated. Also, Escherichia coli is the most common organism isolated in non-pregnant women. In a retrospective study done in 18 years, it was a retrospective study, it was found that Escherichia coli causes about 80% or more than 80% of cases of pyelonephritis in the pregnant patient. But we may also find another organism like Klebsiella, pneumonia, staph, strep, Proteus, and Enterococcus species, but E. coli is the most common pathogens in the cases of urinary tract infection with pregnancy. We will answer the question of why pregnant women are vulnerable to occurrence of urinary tract infection during pregnancy, because the changes, which is immunological changes, and also due to hormonal changes and some anatomical changes. These hormonal and anatomical changes, which is physiological occurrence during pregnancy, is the dilatation of the ureter and also dilatation of the renal calyces occur due to back pressure from the pressure exerted by the pregnant uterus on the ureter, especially the right one. Why? Because the uterus is dextrorotated and dextroverted. Also, progesterone plays an important role. Progesterone causes smooth muscle relaxation. So the compression by the pregnant uterus and the relaxant effect of progesterone make the woman are vulnerable and is predisposed to occurrence of urinary tract infection. Sometimes we find ureteral dilatation. You must know that there is a decrease in the bladder capacity, which usually causes urinary tract frequency that may be a cause of defensive mechanism against occurrence of urinary tract infection. When there is a decrease in urinary tract infection in your bladder capacity, it may lead to vesico-ureteral reflux and the passage of pathogens from downward to upward, downward from the urinary bladder towards the ureter and subsequently towards the renal pelvis and occurrence of upper urinary tract infection. These changes, as we said before, increases the risk of urinary tract infection during pregnancy. Urinary tract infection alone, independently, is associated with preterm delivery, intratriangular restriction, preeclampsia, and increases the rate of cesarean delivery. So it's an important obstetric item and must be treated precisely to prevent these complications. Regarding the classification of urinary tract infection, we have three types of urinary tract infection occurs during pregnancy that may be asymptomatic bacteria, which is the first one, acute cystitis, and upper urinary tract infection, which is acute pyelonephritis with pregnancy. Acute pyelonephritis with pregnancy accounted for about half of the cases, 50%, and acute cystitis is about 30% of the cases, and the asymptomatic bacteria, we will discuss it. It's a very important item. Regarding asymptomatic bacteria in pregnancy, from its name, asymptomatic, there is no symptoms, but there is organism in the midstream urine or clean catch urine analysis shows organisms over 100,000 of organisms per milliliter of urine. If asymptomatic bacteria is untreated during pregnancy, it will lead to subsequent occurrence of infection, namely urinary tract infection, cystitis, and pyelonephritis. So, all the pregnant women must be screened between the 10th to the 17th weeks of pregnancy, must be screened for the presence of asymptomatic bacteria, and this occurs usually in the first antenatal visit, the poking visit. When we found asymptomatic bacteria, it must be treated to prevent further infection and further cystitis and pyelonephritis. As we said before, the organisms that causes asymptomatic bacteria are the same causes of infection in pregnant and non-pregnant female. So we will start antibiotic if we found asymptomatic bacteria, and we will start antibiotic or antimicrobial agent against Escherichia coli. So antibiotic treatment for asymptomatic bacteria is indicated to reduce the risk of acute cystitis and pyelonephritis is in pregnancy, and also to reduce the risk of low birth weight neonate and preterm infant. What are the recommended management protocols for asymptomatic bacteria? We will start antibiotics before the result of culture and sensitivity test. We may start with nitrofurantoin, but not for those near term because it's a hazard on the fetus, and we may use amoxiclav, co-amoxiclav, cephalosporin, and cotrimazole. Cotrimazole is not used in the first or the second trimester. Then, if the culture and sensitivity test result give us another organism, we give the antibiotic for the specific antibiotic for the organism. This treatment must be continued for 7 days. Then we do culture and sensitivity test again after 1 week of completing the course of treatment. And this graph shows the different protocols used for treatment of urinary tract infection in general in the pregnant female and female with asymptomatic bacteria mainly. We may use single-dose treatment of amoxicillin or ampicillin, amoxicillin 3 gram, ampicillin 2 gram. We may use cephalosporin 2 gram, nitrofurantoin 200 milligram, trimethoprim and sulfamethoxazole, which is cotrimazole. We may use 3 days course using amoxicillin 5 milligram 3 times per day, amoxicillin, cephalosporin ciprofloxacin is not usually used because it may all the group of cephalosporin are not used during pregnancy. Regarding the acute cystitis, when we spoke about asymptomatic bacteria, we said that there is no symptoms. There is no symptoms in asymptomatic bacteria. With the occurrence of symptoms, that means the occurrence of acute cystitis with pregnancy, and the symptoms may be urine frequency. The patient has more time to go to the bath, and urgency, and of course dysuria or burning urination. Bacteria without fever and costovertebral angle tenderness usually make concern about the occurrence of cystitis, because costovertebral angle tenderness, if it's present, it will concern about occurrence of pyelonephritis. Sometimes we have gross hematuria. Gross hematuria is the patient tell you that there is a red urine, or the color of the urine become red, and also we found blood or RBCs in urine analysis. So asymptomatic bacteria, there is no symptoms, but in acute cystitis with pregnancy, there is a symptoms which is urine frequency, urgency, dysuria, bacteriuria, and the gross hematuria may also present. In this case, if there is a symptoms, we must start treatment at once, and the symptoms are concerning about occurrence of cystitis. So how can we diagnose, or pre-treatment diagnostic test required for acute cystitis? It may be required, but in some times, and if there is no culture and sensitivity test, we start the treatment at once. If a pregnant woman suspected to have acute uncomplicated cystitis, we may obtain culture and sensitivity test for the midstream clean cut urine specimen. If there is absence of urine culture or no urine culture, the laboratory diagnosis of acute cystitis can be determined by the presence of a significant pyuria, which is pus in urine. We may find more than 8 cells or 8 pus cells per cubic millimeter of uncentrifuged urine, or the presence of 5 pus cells per high power fill of centrifuged urine, or we may find a positive leukocyte trace and nitrite test, which are the result or the diagnostic test for the presence of acute cystitis without the culture and sensitivity test. So we may have 5 pus cells of uncentrifuged urine, or 5 pus cells per high power field of centrifuged urine, or positive leukocyte trace and nitrite test. But usually we start the treatment before the presence or the diagnostic test. What is the treatment of acute cystitis in pregnancy? Treatment of acute cystitis in pregnancy is initiated immediately to prevent the spread infection to the upper urinary tract and prevent the occurrence of pyelonephritis, which is a serious obstetric and general problem. Treatment is done using the same drugs we mentioned before in asymptomatic bacteria, and if there is a culture and sensitivity test, we will change the treatment, antimicrobial treatment, according to this culture and sensitivity test. So when the Escherichia coli remains the most common organism, isolated antibiotics to this organism is initiated immediately, and this treatment is usually safe during pregnancy. How can we diagnose acute pyelonephritis, and what is pyelonephritis? Pyelonephritis is the inflammation of the renal, pelvis, and parenchyma. Pyelonephritis. Acute pyelonephritis is characterized by shaking, chills, fever, flank pain, and sometimes nausea and vomiting, which with or without signs of symptoms of lower urinary tract infection, which is dysuria, and frequency and urgency. When there is a physical examination, and during the physical examination, we find tenderness in the costovertebral angle, and there is tenderness in the costovertebral angle. This tenderness in the costovertebral angle is pathognomonic for occurrence of pyelonephritis. Pyelonephritis, in some cases, we found some non-specific symptoms which are common in any febrile or any infectious condition in the body, like malaise, nausea, anorexia, and vomiting. Thus, the differentiation between acute pyelonephritis and another diagnosis must be done before the start of treatment of acute pyelonephritis. This differential diagnosis include acute intra-abdominal process, mainly infectious process like appendicitis, cholecystitis, and pancreatitis. Sometimes pregnancy complications like preterm labor and placental abruption or intrauterine infection are also giving the same picture of acute pyelonephritis. So the diagnosis is important to start the treatment. Sometimes the patient report uterine contraction during the stages of acute pyelonephritis, which is usually due to irritation of the smooth muscle fiber caused by infection. So the patient must be assessed well, and cervical dilatation and the occurrence of cervical infection, and we may take a swab from the cervix for culture and sensitivity test to diagnose cervical infection during the initial visit or the initial admission to the hospital. So the patient must be monitored closely. However, preterm labor may develop at any time. Sign and symptom of sepsis may also present, and there is a general septicemia like fever, pallor, yellowish discoloration of the skin and the mucous membrane, which indicate jaundice, and may sometimes there is admission to the ICU and tachycardia, hypotension. Such patients require prompt evaluation and intervention if there is a case of general septicemia, which is a serious condition. It's a serious condition, and in this case, management protocols require the presence of anesthesiologist and obstetrician at the same time. So, regarding the examination and the signs of acute pyelonephritis with pregnancy, we must do a full physical examination with a special attention to the vital sign. You must know that in the reversible shock there is usually tachycardia, but if there is a general and deep septicemia, the vital sign may show bradycardia and sometimes cold extremities, which is in the stage of septicemia. So the monitoring of the vital sign are very important, and we must examine the heart and the lung for the symptoms of septicemia. Also, an abdominal examination, it will reveal tenderness in saline region and costovertebral angle tenderness, which is sometimes pathognomonic for occurrence of pyelonephritis with pregnancy. Also, we must do a genitourinary examination for assessment of the degree of cervical dilatation and the presence or absence of cervical infection, and this usually occurs during the at the time of admission. Even when pregnancy complications are not a concern initially, it's still reasonable to evaluate the contraction or other abnormalities occurred during hospitalization. Why? Because usually urinary tract infection causes irritation of the uterine muscle and uterine contraction, and maybe the occurrence of preterm labor. Usually the clinical picture is clear and the diagnosis of pyelonephritis is clear, but sometimes we need to do urine analysis and clean catch urine. The presence of cast in the urine examination Differentiate between occurrence of pyelonephritis and cystitis. The causes are present in cases of pyelonephritis. Complete picture which will show the presence of leukocytosis more than 11,000 cells per cubic millimeter, and the presence may be the presence of sepsemia in the form of anemia. Electrolyte and serum creatinine to show the renal function test, and sometimes we need to do amylase and lipase to estimate their level in the blood to diagnose pancreatitis if it's considered as a diagnosis. If the concern for sepsis, lactic acid and blood culture must be obtained. When there is a culture and sensitivity test result, you must change the antibiotic towards the culture and sensitivity test. But at the start, we will start treatment with triple antibiotic. Then, according to the culture and sensitivity test, we will change the antibiotic towards them. When the fetus is viable, fetal heart rate and uterine contraction should be assessed to know the fetal well-being, and we must do concern about the cervical and gram-positive staining culture on admission in pregnancy complication develop. Sometime renal ultrasound may be indicated to assess the presence of renal abscess. In these cases, it must be trained before the treatment. The only treatment of renal abscess is drainage, and this drainage may be done through ultrasound drainage and insertion of a pigtail in the abscess, which is a ultrasound directed nephrostomy. We cannot manage this patient without drainage of the renal abscess. When the sepsis occur and the sepsis become more worse, it will result in hypotension, tachycardia, and decreased urine output. In this case, ICU admission is required and is important and inevitable, because the adult respiratory distress syndrome can occur at any time, which occur due to endotoxin-mediated alveolar damage. These endotoxins are released from the organism, and this is manifested by pulmonary edema with acute respiratory distress. This also, the organism also can release endotoxin towards the systemic circulation, which lead to hemolytic anemia and destruction of the RBCs. Endotoxin also causes uterine contraction, which is subsequently results in occurrence of preterm labor. Sometimes the occurrence of acute pyelonephritis leads to chronic pyelonephritis and the persistence of infection. Regarding the treatment of acute pyelonephritis in pregnancy, pregnancy is a serious condition and must not be treated at home. Hospitalization is mandatory once an evaluation has been completed and the diagnosis is established. Treatment consists of good antibiotic. We start with triple antibiotic against gram-positive, gram-negative, and neurobes. We start plenty intravenous fluid to maintain washing of the organism through adequate urine output. So washing of the organism from upward to downward is very important, and we treat the high temperature or fever by cooling blanket, and acetaminophen is needed. Commonly, second or third generation cephalosporin are used for the initial treatment. Also, we may use ampicillin and gentamicin or another broad spectrum antibiotic. We will start by intravenous antibiotic, and it's continued for about 48 hours after the last febrile period. Then we shift towards the oral antibiotic. We must change the patient position, and the patient position should be in the opposite side of tenderness to relieve the ureteric compression. And sometimes we may need the insertion of ureteric caster to relieve the compression and to wash the pus and the infectious material from the upper urinary tract towards the urinary bladder for drainage. But Unfortunately, this usually lasts for about 1 week, 2 or 3 weeks, and then removed, because at this time itself it will be the source of infection. So in some cases, to relieve the pressure on the right or left side, or relieve the pressure of the pregnant uterus on the ureter, we may insert ureteric catheter, but as we said before, it starts or it lasts for 2 to 3 weeks maximum. This is the end of our slide, and thank you.